Thank you, Ken, and thank you for inviting me here. This is kind of the outline of what I want to talk about, and it has to do with is the health and medical response that has evolved in response to these wildfires. In California, the Emergency Medical Services Authority, which is the EMS side department within the Health and Human Services Agency, we partner with the Department of Public Health for the emergency support function, EF8 or ESF8, which is public health and medical. And we had been planning in California for decades, primarily for earthquake, which is our probably biggest catastrophic threat, and even floods. But we hadn't done specific planning for fires. And so our response to fires has all been empirically developed. Obviously, the same emergency management principles apply to fires, but there's a very distinct pattern of need that's emerging and of the impact on populations. So if you think about it, the first thing you have to do is the EMS has a role, Emergency Medical Services has a role, both its usual function of, you call 911 and someone responds, but also in the evacuation of health facilities. And so the first priority in any disaster is life safety, saving lives, minimizing suffering. And so we get involved in evacuation, and patient movement is very big during these fires. Then there's medical care for the displaced populations. And this is usually in the surrounding communities and can extend quite a ways out, including obviously all the way to Davis. Davis is the closest big medical center and population center to the recent Camp Fire, and provided a lot of medical support, not only sending their students and other healthcare workers up to Chico area, but accepting a lot of the patients that had to be placed. And then I'm going to mention a new challenge that hasn't been mentioned yet, but I hope will be discussed over the next 2 days, which is, PG&E, our utilities have been blamed for these fires, which is a huge liability. As was mentioned, the cost of these fires is immense. And their power transmission lines have been accused or have been identified as the source of these fires, because you got to remember that the climate conditions that these fires occur in is usually towards the mid or end of summer. And in California, we have what they call the Indian summer. September and October are very dry, and there's offshore winds. As opposed to onshore winds, which are quite moist, the offshore, the onshore, let me get it straight here. The offshore winds are quite dry because they come from the desert. But not only that, there's usually very high wind velocities. So we're getting gusts of 50 to 100 miles an hour driving these fires, which is why no one can think of stopping them. So I want to show you just through pictures mostly how this response looks and draw some lessons from it. So first you see the EMS response, and a lot of it is done typically by the ambulances that usually service our 911 response. But that's quickly overwhelmed in these rural areas. So our mutual aid for EMS looks like first you pull other units in from the response area, which the units that may have been used for interfacility transport and others, not just the 911 units. Then we have these ambulance strike teams, which can come from regional areas. And we have about 41 of these around the state, and they come from other jurisdictions with 5 ambulances plus a leader vehicle that can resupply and keep them in the field for 3 days without having to go back to their base. And then if we need it, we would call on a national ambulance contract, which is used quite often in the hurricane areas of the southeast, but has rarely been used here, although we did have them staged once for the Mendocino-Napa-Sonoma fires. We have not really used them yet, but we can get hundreds of extra ambulances from out of state, but we have a big enough state that we can call mutual aid from other parts of the state. Now, this is what an evacuation of a facility would look like if you had warning. So you've seen maybe when the hurricanes are coming and they're evacuating a hospital, you see dozens of ambulances lined up waiting to pick up patients at a hospital and move them out of harm's way. This was actually a repatriation event that I'm going to get into, but we had ambulances and wheelchair vans and buses, you know, all levels of transportation staged, and you call them up and pick up people in a very orderly fashion. Well, that's when you have time. Here's what it looks like in our wildfires now. This is the evacuation of Feather River Hospital up in Paradise. And it's not EMS with ambulances lined up, although whatever ambulances are available are coming to their aid. It's the employees of the hospital. It's the nurses, the doctors, and anyone else, the visitors and fire personnel that just grab patients and take them out of the hospital and load them not only in ambulances, but in any vehicle available. This is another one. This was in the Napa-Sonoma fires. This is an evacuation of a Kaiser hospital in Santa Rosa, and it doesn't look like you can see this very well because it's so smoky you can't see much of anything. But they're pushing an ICU bed. You know, the patient's got lines and everything else, you know, out of that hospital and hoping they'll have a vehicle to evacuate them in. So what our agency, which our Health and Human Services Agency in California, has responsibility, statutory responsibility for organizing EF8 and also EF6, which is shelter, you know, basically. And so they're really, in response to these fires, have gotten very serious about tracking facilities. I mean, we always kept track of, oh, is this hospital evacuated or in business, but we never kept the kind of detail that we do now, where we're looking at all our licensed facilities, not just acute care facilities, not just the long-term care facilities, but any kind of convalescent home, and even all of our facilities that are licensed by our Department of Social Services, residential care facilities. We have to be able to track all these kinds of facilities and see whether they're still in business, whether they're evacuated, and what happened to their patients. So we've now got these dashboards where the departments that have licensing responsibility are tracking and feeding these numbers, and we finally have accurate maps. We can download the fire perimeter maps, we can download smoke plume maps, and we can overlay those with the locations of known facilities. And so we're able now, and it's a very important function, to be able to track what's going on in the health, medical, and social services area. During the Napa-Sonoma fires last year, we had to evacuate a developmental center. This is a center where most of the residents are lifetime residents. They're severely disabled, mentally, physically, in any way you can imagine, and they're long-term chronic residents there. And this facility was in harm's way. They evacuated it to downtown Sonoma. The fire kept coming. They said, we have to move them further away. So they actually had to evacuate this population twice. And they took them all the way to Dixon Fairgrounds, about 50 miles away. This is kind of south west of here, off of Highway 80. And we evacuated 241 patients. And I remember the HHS secretary called and said, we need to take their beds. I said, we have beds, we have hospital cots, and we have cots for disability. He goes, no, you don't understand. They need their beds, because these people have very specific beds for their contractures and their their body habitus, and wheelchairs that are, you know, powered wheelchairs that are designed specially for them. So this is where we had to set up basically a mobile hospital at the Dixon Fairgrounds. We used an open space like this to create the hospital. And, you know, we had to bring, fortunately, we were able to get their medication carts and a lot of the things out of the facility, because the facility wasn't burning, it was just the fire was coming down on it, though. And we had to basically recreate a hospital. Now, this is something that we'd always talked about doing, but never had to do before, because we've always been able to evacuate patients to like facilities and put them in other hospitals. But this population was so unique that we needed to maintain the environment. I mean, their needs are so specific and complex. Fortunately, the only thing that basically saved us was that the staff was so committed that the staff came with the patients. So the staff left their community and traveled to this fairgrounds and stayed there to take care of those patients. Because these are not the kind of patients where you could just get some doctor from a local facility and say, come in and take care of these people. It's not the same. Obviously, we needed a lot of accessible facilities and staff headquarters and food service. So it was, let me go back here. I want to just finish talking about this. It was an incredible endeavor and a very difficult one. So this is the type of thing that we have to get used to now, of how do we care for all these evacuated facilities? And can we use like facilities and distribute them into those? So I want to just mention the campfire now, and this is the incredible, statistics. We had to deal with up to 50,000 evacuees and 86 fatalities. And this is where inequities comes in. Most of these were elderly. This was a retirement community. And most of these people were in their 70s. They couldn't get out fast enough and get away from this fire fast enough. So they ended up in multiple shelters like this. 10 of these shelters opened up in Chico, Oroville, and the surrounding communities. And it was our job to provide medical care for these. Now, one interesting thing is that the disability community, the access and functional needs community has been pushing us, treat everybody in the general population shelters. We do not want people having to go into medical shelters. And we've been trying that, and for most of the fires it worked. But there was something about Paradise. It was an elderly community with a lot of health problems, and you could not necessarily easily treat them in general population shelters. So we put together medical teams of various different, we have our CalMats that are like DMATs. We brought in National Guard, we brought in federal, we brought in local. You're going to hear from Andy Miller, who provided a lot of staff from everywhere from Davis to Chico and surrounding communities to help us. And we put together integrated health teams to work in these shelters. Usually, Red Cross nurses that just do first aid are adequate, but there was no way this population could be cared for without a much higher level of medical need. So every one of those shelters had to have a medical operation because we weren't routing people to specific medical shelters. These are what some of the clinics or medical facilities looked like in those shelters. We had to set up whole pharmaceutical areas, and this is always one of the most critical needs in any rapid moving disaster where people have to evacuate quickly. They don't have their medications. And so replacing medications is extremely difficult. We were able to provide, we have a pharmaceutical unit, but also we finally availed ourselves of the federal program, EPAP program, Emergency Pharmaceutical Program, that is for uninsured patients and allows them to fill prescriptions at no cost. We also have a program where we're able to access medical records through Health Information Exchange, which we use and switch on during a disaster. And that's been very helpful, not only for knowing what medication someone's on, but what their problem list is. But then here's the public health risk. You saw what those clinics looked like. I mean, the shelters looked like. Well, we had norovirus break out in a shelter. So imagine being cots 2-3 feet apart from each other in a huge room, and someone starting to have vomiting and diarrhea. And norovirus can be aerosolized. So we had an outbreak that was really starting to get out of control and difficult to maintain. And this is where public health came in. They sent in infection control nurses that were going daily from shelter to shelter. You can see on the bottom here at the front of this station all of the infection control things, gloves, hand wipes, sanitation stuff. And that wasn't enough, though. It was the practices that we needed to get together. We had about a third of the Red Cross ratio of toilets and showers to population was grossly inadequate. We had to triple it, and we had to get them cleaned. And you can see there, which worker do you think is going to be getting sick? You know, the workers finally started getting adequate protection. And then what we had to do was set up isolation tents at every shelter so we could isolate the sick and keep them out of that general population shelter. And finally, it enabled us to get on top of this. But then we were headed into flu season. So we wanted to get ahead of that and started giving flu shots. All of this takes a huge amount of management. And so we had to have incident management teams, both in the field, back at our department, to manage the logistics of this was considerable. And these were some of our management teams. These were teams that were on site at the different shelters. So then I just want to close with a last comment of opening this issue of voluntary power shutdowns, because now the power companies are telling us when the winds start to blow and the weather's dry, we're going to turn off the power because we don't want to be held responsible for fires. So then what are we going to do with all our power-dependent patients? They're throughout the community, and we don't know exactly who they all are, although HHS, federal HHS, is sending us these long spreadsheets listing all the CMS patients, but there's so many of them, I mean, it would just blacken the map if you were to put dots on it. So we have to figure out how to do this, and we have not figured this out yet. And not only that, we don't want them to turn, we asked them, can you spare the medical facilities? They said, no, it's just all one big grid. So we might be evacuating medical facilities because we won't know how long the power is going to be out. And their generators don't often last a long time. So we're going to be looking at, we have to protect our emergency departments from people coming in to plug in. So we're going to be looking at setting up power shelters. So I hope this is a topic that is considered in more detail here, and I'm sorry to go a few minutes over. Thank you very much.